I'm Dr. Ara Deuk. I'm here today to discuss advances in anterior cervical endoscopic disc surgery. In particular, we're featuring the Deuk laser disc repair. Anterior cervical endoscopic disc surgery has been performed and published in peer-reviewed journals by several different authors. Some of the publications available in PubMed are listed here on this slide. There are various authors from around the world who are generally neurosurgeons or orthopedic spine surgeons that have published their results from their studies performing anterior cervical full endoscopic disc surgery. Here we have a table that lists several of the publications over the last 10 years. Most of the studies are prospective cohort studies or Class 2 data. The number of patients in each study is listed in column 3, and the follow-up on average for each of these studies is listed under the follow-up in months. Symptoms that were targeted for the surgery in each of these studies are listed under the symptoms, and most of the studies that were done looked at neck and arm pain, and the outcome measure was generally reported as either excellent or good using a McNabb, modified McNabb scale or a Prolo score. And you can see that for the most part, the outcomes with respect to resolution of neck or arm pain for treatment of cervical disc disease that's symptomatic was in the 80 to 90% range. Our study was published in 2013 with respect to outcomes regarding neck and arm pain in Surgical Neurology International, and our patients experienced a 95% resolution of neck pain, arm pain, radicular symptoms, and headaches overall. Today we're going to talk a little bit about the Deuk laser disc repair on the cervical spine. The procedure is done through an anterior approach to the cervical spine. The surgery is a full endoscopic surgery. The entire surgery is performed through a 4 millimeter working cannula under endoscopic visualization. The procedure is performed through a transdiscal approach, going from anterior to posterior, preserving the disc that is being treated. The surgery is a motion-preserving surgery. There is no fusion being performed. There is no loss of segmental motion related to the surgery through anything that's done during the surgery, such as instrumentation or arthrodesis. There are no implants. The surgery is performed using a laser. The laser used is a holmium YAG laser. This is a medical-grade laser. The laser fiber is 550 microns in diameter, or approximately 0.5 millimeter in diameter. The laser fiber and laser energy is directed under direct surgeon control at pathological tissue visualized endoscopically within the disc and the neuroforamen and the spinal canal. The surgery is typically performed outpatient. Deuk laser disc repair target symptoms include discogenic axial neck or back pain, radicular extremity pain, radiculopathy, or other radicular symptoms such as numbness, paresthesias, or weakness. Many of the patients also had headaches that were generally temporally related to onset of neck pain and occipital region headaches. These headaches improved after surgery and were felt to be related to the discs. These are discogenic headaches, otherwise reported as cervicogenic headaches originating from the cervical spine. I want to take a moment to briefly discuss discogenic axial pain. This is pain in the neck that is axial in location as opposed to radicular. And this is pain that we believe is originating from the disc. And this is determined preoperatively through a series of treatments and tests, which I'll elaborate on more as we go along. The indications for Deuk laser disc repair, anterior cervical endoscopic surgery, is that a patient must have the aforementioned symptoms, either one or more. They must fail appropriate conservative management, such as therapy. This can be physical therapy or combined physical therapy, chiropractic, or self-exercise program that's appropriate. We require the patients also fail an interventional pain management treatment, specifically with respect to facet syndrome. We want to be certain that the patient is not suffering from facet pain, which can present as axial neck pain or radicular type pain into the shoulder and upper arm. This can be eliminated as a source of pain by performing a simple interventional diagnostic test known as a medial branch block, where the interventional pain management physician or surgeon can essentially, using a needle and fluoroscope, numb up the facet joints, either by numbing the joints themselves or blocking the medial branch of the dorsal ramus to a series of joints. If the patient experiences relief of their pain as a result of this block to the facet joints, then we know that some of the pain is related to the facets, and we treat that with a rhizotomy before any surgery is performed. Patients who fail to improve with medial branch block or rhizotomy are believed to have pain coming from their discs or disc-related pathology. If we have any questions at that point as to the source of the neck pain or arm symptoms, we will perform a discogram using the MRI scan or CT scan to determine which levels to perform functional discography on. And this is usually based on structural abnormalities within discs in the area of the spine that we believe is related to the source of their pain, based on their physical exam and history. Preoperative imaging for this procedure includes an MRI scan of the cervical spine, which can show annular tears with contained or non-contained disc herniations. Functional discography is used to determine if concordant pain is present in specific discs that have anatomical abnormalities seen on MRI scan. And a post-discogram CT scan is performed after functional discography to study the internal architecture of the disc, specifically the annulus, and to assess the location and degree of annular tears that could be causing patients' symptoms. There are two peer-reviewed publications regarding the Deuk laser disc repair. The first publication was published in Surgical Neurology International in 2012, entitled Cervical Deuk Laser Disc Repair, a novel, full endoscopic surgical technique for the treatment of symptomatic cervical disc disease. In this study, we did a prospective analysis of all patients treated with cervical Deuk laser disc repair over a 4-year period, and we determined that there were no perioperative or postoperative complications from the surgery. The average operative blood loss was less than 5 cc's. The average volume of disc material removed was 0.09 milliliters. All of the procedures were performed in a licensed outpatient surgery center by the same surgeon. All patients were discharged home the same day as the procedure, and there were no hospital admissions or emergency department visits related to the surgery. In the next study that was peer-reviewed and published in 2013 in Surgical Neurology International, the Deuk laser disc repair is a safe and effective treatment for symptomatic cervical disc disease, is a prospective Class II study that demonstrates in 66 consecutive patients that underwent disc repair for 1 or 2 levels of symptomatic cervical disc herniation or disease. The average symptom relief was 94.6% with respect to neck pain, arm pain, cervicogenic headaches, and radicular symptoms. 50% of the patients had 100% resolution of all preoperative symptoms Only 4.5% of the patients had less than 80% resolution of their preoperative symptoms. Visual analog score improved from 8.7 preoperative on average for the cohort down to 0.5 postoperative, with a p-value less than 0.001. The average operative and recovery times were reported at 57 minutes and 52 minutes. There were no perioperative complications. Recurrent disc herniation occurred in one patient, which represents less than 2% of the patients had recurrent disc herniation. Our average follow-up time was 3 months. There was no significant difference in the outcomes between patients that had follow-up for 3 months or less versus those patients with a mean follow-up of 319 days. There was no significant difference in the outcomes between patients having 1 or 2 level Deuk laser disc repair. However, patients that were diagnosed postoperatively with cervical facet syndrome did indeed have a worse outcome with respect to symptom relief compared to those patients who did not have cervical facet syndrome, and the difference was significant, with a p-value less than 0.001. The Deuk laser disc repair is an endoscopic surgical procedure that incorporates advanced, minimally invasive techniques that require additional training to develop the unique skill set needed to safely and effectively perform the surgery. Prior to performing the Deuk laser disc repair procedure, a surgeon must receive specialized training through an individualized fellowship. We're going to begin with a patient history. This patient is a 26-year-old male who has suffered with chronic medically refractory neck and arm pain with numbness and paresthesias in the left hand. The patient failed conservative management. The patient had, on physical examination, unilateral radicular dermatomal and myotomal deficits. The patient's MRI demonstrated multi-level cervical disc disease with associated foraminal stenosis. A discogram was done preoperatively, which demonstrated concordant pain, rated a 9 to 10 over 10 by the patient, who claimed that this was his typical pain, at multiple discs. Post-discogram CAT scan demonstrated grade 3 and grade 4 annular tears within different discs that were treated.
The primary symptoms that I have are, first of all, really sharp shooting neck pain whenever I try to move my neck in any direction. I also have headaches, occipital neuralgia caused by the same problems with discs. And the pain would also spread into my shoulders. It would spread into my arms, specifically in my left arm.
Preoperative MRI shows contained disc herniation.
Now, this patient's post-discogram CAT scan demonstrates an annular tear in the posterior annulus, which can be visualized, pointed at by the red arrow. This contrast material, which is white, can be seen extravasating through the annular tear into the epidural space. The operating room setup for the Deuk laser disc repair requires an anesthesiologist, as general endotracheal anesthesia is required with complete muscle relaxation, a fluoroscopic technician with recording system and high-quality fluoroscope is required, an endoscopic rig with endoscope, cameras, and high-definition endoscopy capability is required. The surgery is performed under sterile prep and drape with general endotracheal anesthesia, and we'll begin our video demonstration of the surgery. The OR is set up as you typically would set up a spine OR, with the patient in the supine position. There's, again, the neck is sterilely prepped and draped. We use Ioband to minimize risk of infection. The endoscopic equipment is sterile. The fluoroscope is covered in a sterile drape. The fluorotech is available for multiplanar imaging. All right, the first step after prep and drape is to basically find a plane. The patient is intubated, paralyzed, chemically paralyzed, and that allows the Parapharyngeal muscles to relax, so there's no gag reflex, which is important. And I'm palpating the anterior spine. Most likely I'm palpating 5-6 right now, the disc space. Let's go ahead and get a needle. My fingers are just medial to the carotid sheath and its contents, and lateral to the trachea and esophagus shot. We're going to use lateral fluoroscopy to localize the correct level. We're going to start at C5-6. A patented 18-gauge spinal needle is used for access. Let's go ahead and get an AP fluoro. And that looks good. Let's go back to a lateral. We're going to use 2 planes of fluoro, AP and lateral. This is a beveled needle shot. That looks pretty good. All right, we're in the disc space. Let's get an AP. I'm going to verify the correct position of the needle through AP and lateral fluoroscopy. Essentially, the tip of the needle is in the center of the disc space. Let's go ahead and perform our discogram. And shot. Good. Dye went in fine. Let's get an AP. Coker. All right, looks good. Go ahead and go back to a lateral view. I'm going to take a guide wire. I'm placing the guide wire through the 18-gauge needle. We're going to remove our needle. The guide wire remains in the disc space shot. Shot. All right, so we're still in good position, and again we're at C5-6. We don't go too deep. We're going to make a 4mm incision with the scalpel. We're using a number 11 blade, and we're going to bring the dilator over the guide wire. Being careful not to advance the guide wire. Lateral. And you can see the tip of the dilator is passing lateral to the trachea and esophagus, medial to the carotid sheath. We use a rolling motion to get the dilator tip abutting the anterior disc space and spine shot. We use lateral fluoroscopic guidance. Now, right now we're up against the anterior longitudinal ligament with the tip of the dilator. Right, should be in the center of the disc between the longus colli muscles. And let's go ahead and get an AP to verify. And you can see that the tip of the dilator is abutting the anterior disc space virtually in the midline. And let's go back to a lateral view. Shot. Very good. We're going to go ahead and advance the dilator through the disc space at this point under fluoroscopic guidance. Shot. And we've just started to enter the anterior longitudinal ligament. We're going to take the guide wire out. I need a mallet. Shot. We're going to follow this with lateral fluoroscopy. Shot. We're going to bring the tip of the dilator to the back of the disc. Shot. All right, very good. And now we're going to place our working channel. The working cannula is 4 millimeters external diameter. You can see the blood loss is minimal with this surgery, maybe a few drops. And we're feeling for that working channel or cannula to abut the anterior spine. Patient's neck is slightly extended. Shot. Very good. We need to advance the working cannula through the disc space using lateral fluoroscopy. Shot. 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 Let's get an AP, verify position. So we're aiming for the posterior disc space off to the left side of midline. That's exactly where we're going on the fluoroscopic image, as his symptoms are in his left arm. Let's go back to a lateral view, please. No. I'm going to advance it more. Shot. We'll confirm the position of the working cannula. And the tip is near the posterior annulus where the herniation is. We have a suction tube, and we're ready now to bring in the endoscope camera.
You have all your specialties still?
All right, we're going to go down. All right, so we're introducing the endoscope down through the working channel. We'll start the irrigation. Go ahead and record. Zoom in. We bring the laser fiber into position. It's about 2 millimeters in, past the end of the cannula. You can see the laser fiber has a targeting beam, and we should be on 20.
We are, we're ready at 20 watts.
All right, 20 watts. All right, what we're seeing here is the laser fiber in action. The targeting beam is slightly orangish red, and you can see I'm manipulating the camera, rotating it to be able to move the tip of the laser fiber and direct laser energy to where it needs to be. Here we're going to be reaching in and grabbing out a fragment of the disc herniation that's, as you can see on this x-ray, located in the back of the disc where the herniation is actually compressing the nerve root. This represents a small fragment of disc herniation removed from the working cannula at the posterior margin of the disc where the disc herniation was. We'll reintroduce the endoscope and camera, and the surgery is essentially a series of cycling between using the endoscope and laser and removing fragments with the pituitary rongeur. Here we have the end result, a 4 millimeter incision. This patient had 2 incisions because they had 3 discs repaired. The wound is sutured close with a resorbable suture. You can see that multiple fragments of disc material were removed, representing approximately 5% of the total disc volume. Deuk laser disc repair has essentially 3 distinct endoscopic components. The first is a discectomy, and the discectomy involves the removal of both interposed disc material, which is the nucleus pulposus that has extruded from the center of the disc out through the annular tear and is actually interposed. If you think of the outer annulus to the inner annulus, that has a width. The interposed disc is that disc material or nuclear material wedged into between the annular edges. The extruded material is that disc material or nucleus material that is extruded past the outer annular layer and maybe in the epidural space or maybe subligamentous to the posterior longitudinal ligament. The Deuk laser disc repair discectomy is removal of both the extruded part of the disc or nucleus that's found outside of the outermost annular layer, and the interposed again is that nuclear material that is wedged between the edges, torn edges of the annulus. It's important that both components are removed to have the optimal effect of the surgery. The second part of the surgery involves an annular debridement, which essentially is a very important step using predominantly the laser and the laser energy to remove the edges of the annulus that are inflamed and devitalized to allow the annulus to heal itself properly. The last step is the foraminoplasty, where we enlarge the foramen where the exiting nerve root is to decompress the nerve root. We'll go through a series of videos here to highlight these different steps, and the first one will be focusing on the discectomy component of the surgery. We can see the cannula and the laser fiber. The disc is stained a light blue. This stain is applied during the discogram portion of the surgery, and the light blue stain is actually indigo carmine at 10%. The indigo carmine binds to degenerating nucleus and allows us to see the degenerating nuclear material that's usually part of the herniated disc. Again, laser energy is being applied through the laser. When small fragments of herniated nucleus are released from their attachments to the surrounding annulus, they can be removed with a modified pituitary rongeur designed for this application. What we're going to highlight here now is what we call the reverse herniation. If you think about a disc herniation as extruded nuclear material outside of an annular tear, if you release the tethering of the nucleus that's herniated, many times that nuclear material will reintroduce itself backwards into the disc space posteriorly. And that's what we can see with some of these video clips. The laser is actually used to release the nucleus pulposus fragments that have herniated out. Those nuclear fragments that have herniated out into the between the annular tears create a tremendous amount of inflammation within the outer annulus. The outer annulus is innervated and does have a blood supply. The outer half of the annulus blood supply is instrumental in creating an inflammatory response that occurs in the outer annulus that over time brings with it granulation tissue with neovascularization, new endothelial cells, and new nerve fibers that are nascent and unmyelinated. We believe that the outer annulus inflammation is probably the most important part of creating axial discogenic neck pain, and we use a laser to debride and remove this inflammatory tissue within the edges of the annular tear to also allow releasing the herniated interposed disc material and extruded disc material, because they typically elicit such a strong inflammatory response that they are collagenized fragments and scarred into the annulus. The laser energy allows us to easily remove these fragments by detaching them from the annulus and allowing the pituitary rongeurs to remove the larger fragments. We'll go ahead and watch a reverse herniation. And laser energy is again being applied to the annulus here. There's a small fragment of herniated nucleus pulposus that was extruded out past the outer annular layer. This is another example of what we term a reverse herniation. We're working between the end plates of the vertebral body posteriorly, and you can see that the laser detached or opened up essentially a channel for the herniated extruded disc fragment to come back into the disc from the epidural space back into the disc. Now, some of this force on the nuclear fragment may be coming from the posterior longitudinal ligament. If this is a subligamentous herniation, for example, the ligamentaxis of the posterior ligament will push the fragment in. Here we have a large herniated fragment that was removed. The next step in Deuk laser disc repair is an annular debridement. Annular debridement involves, again, using the laser energy to debride the annular edges where the tear occurs and to remove any residual nuclear material still attached to the annular edges. This will allow us to remove devitalized material and inflammatory material within the annular edges. This allows the annulus to heal over time after surgery. Again, laser energy is directed at the annular tear. We're removing interposed disc herniation material. And there's continuous irrigation fluid moving through the working cannula into the operative field. This irrigation is cooled in a refrigerator. It keeps the tissues from overheating and causing thermal damage to surrounding structures. This video clip shows a little bit better the annular tear and the interposed nucleus pulposus that is herniated out through the annular tear. We're going to remove that interposed disc herniation and debride the annular edges so that the annulus can heal into a pain-free state. The theory here is that the annulus wants to heal after a tear occurs. However, in some patients, the interposed nucleus pulposus prevents the annulus from healing and creates a repetitive cycle of inflammation within the outer annulus that brings in small nerve fibers that are very pain sensitive, and this generates the axial discogenic pain that people feel when they have chronic neck or back pain that comes from the disc. Here's another large fragment that's being released and removed. You can see the essential role that the laser plays. We're working in such a small space. The inner diameter of this working cannula is about 3 millimeters. There really are no surgical tools that are designed to be able to do this kind of work aside from the laser. And again, the diameter of the laser fiber is 0.5 millimeter. The laser is very safely and effectively removing herniated fragments. You can see most of the herniated fragments do come out in pieces as fragments rather than one whole big piece. Rarely will the herniation come out as one whole piece. Here we're debriding the annulus, which is white, and the interposed degenerating nucleus that was herniated is blue. You can see it's wedged in between the annular tears. The annulus wants to heal, it's unable to do so because of the interposed nuclear material, hence necessitating removal of the interposed nucleus as well as debridement of the annulus to allow it to heal postoperatively. You can see torn annulus fibers there. At 10 to 12 o'clock, the laser is being used to debride. Large fragment. The final stage of Deuk laser disc repair, or the last of the 3 steps, is a foraminoplasty. This involves widening the foramen back to its original caliber to allow the nerve roots to be decompressed as they exit the spinal canal. Foraminoplasty can be performed endoscopically using the laser, as seen here. What we're seeing as the end plates of the two vertebral body. Those are some small bone spurs at the posterior margins of the end plates, and the laser is actually working on removing herniated disc material in the neuroforamen. The nerve root is just deep to where the laser tip is. That material that's being removed is herniated fragment of nucleus that is highly collagenized and scarred. Again, the laser is just removing herniated material in the foramen, opening the foramen up, also removing small bone spurs that are contributing to foraminal stenosis. Foraminal stenosis occurs because of several mechanisms. One of them is the formation of spurs, another is the herniation of disc material, another is thickening of ligaments and capsule, another is the collapse of the disc space. Here we are just removing again fragments of disc herniation from the foramen, widening it to allow the nerve roots exiting to be decompressed. This can be done without performing fusion or destabilizing the segment. The end plates are to the left and right. We're visualizing the posterior longitudinal ligament in the middle. There's a blue line from 6 o'clock up to 12 o'clock. At 12 o'clock we have the neuroforamen. You can see the working cannula can be adjusted by either pulling it back or moving it forward, advancing it into the foramen, and using the laser to remove herniated disc material in the foramen, bone spurs, and thickened ligament, all contributing to foraminal stenosis. The laser is at the base of the uncinate process. We don't remove the uncinate process, but part of the uncinate process can be removed if necessary. You can see the uncinate process near the laser tip. And currently we're in the left foramen at C5, C6. Sometimes the view is partially obscured by particulate matter, which is the blood or small fragments of tissue that are being removed by the laser. We can work our way right out through the foramen, even visualize the nerve root, if necessary, directly with the endoscope. We're just peeling off layers of herniated disc, one layer at a time. Many people mistakenly believe that the laser cannot be used to remove bone. However, small to medium-sized bone spurs can be removed quite easily with a holmium YAG laser using 20 watts of energy. As we'll see in this next video, we're going to remove some small bone spurs and osteophytes in the disc that allow us to decompress the nerve root. The whitish cream gold color is actually the osteophytes, and the laser is actively removing those osteophytes very safely. Now, we're about 30 minutes after surgery, and tell me about the numbness and tingling that was in your hand before surgery.
Well, the numbness and tingling is gone completely.
Very good. He also had pain radiating from his neck into his left arm. And how is that doing at this time?
That's about 80% gone.
Great. Now he had axial neck pain, which we believe was discogenic neck pain as well. And sometimes it's very hard for patients to appreciate any difference in that for the first few days after surgery. And can you tell any difference in your axial pain deep in the center of your neck?
The pain is about the same as before surgery in the back of the neck.
Okay. And you also had headaches, pain radiating from your neck up into your back of your head.
That's about 70% gone.
Fantastic. All right. As you can see, he is wearing a collar. All the patients that have the Deuk laser disc repair wear a collar for 6 weeks to allow the disc to heal. And there's his incision. He has 2 incisions that are 4 millimeters each. Do you have anything else you want to add?
No, but I do feel pretty good after the surgery.
Good. Very good. All right. We'll see you later. We're going to get you out of here probably in about 10-15 minutes.
Okay.
All right, so we have from our second paper that was published the outcomes of patients that were in the prospective cohort. There were 66 consecutive patients treated with 1 or 2 symptomatic cervical discs, and the results are, with respect to the patient-reported outcome of resolution of symptoms, preoperative symptoms, specifically neck pain, arm pain, radicular symptoms, and headaches. The patients achieved overall 94.6% resolution of their preoperative symptoms as a whole, on average. 1/2 of the patients, or 33, had 100% resolution of neck pain, arm pain, headaches, and radicular symptoms. 23 patients had between 90 and 99% resolution of their symptoms. 7 patients had between 80 to 89% resolution of their symptoms. And only 3 patients out of 66 had between 55 and 79% resolution of their pain and radicular symptoms. Looking at the VAS pain scores for the entire group, preoperatively, the average VAS was 8.7, post-op average VAS was 0.5. This is significant difference with a p-value of 0.001. There was really no significant difference in outcomes with respect to patients who had 1 disc treated versus 2 discs treated. The number of patients that had 2 symptomatic discs treated with Deuk laser disc repair in a single procedure were 45. The patients that had a single disc treated was 21, and there was no significant difference in their outcomes. The patients who had developed postoperative facet syndrome, which is pain coming from the cervical facet joints along with stiffness of the neck, those patients had a significantly less improvement in their preoperative symptoms at 86.8% average resolution of preoperative symptoms compared to patients who did not have postoperative cervical facet syndrome. The patients who did not have postoperative cervical facet syndrome achieved a 96.4% resolution of all of their preoperative symptoms. The difference between the 2 groups was significant. We believe that the patients who had less improvement in their preoperative symptoms was a direct result of the fact that they developed postoperative cervical facet syndrome. In conclusion, Deuk laser disc repair is indicated for either discogenic neck pain, arm pain, cervicogenic headaches, radiculopathy, or radicular symptoms in patients that have failed appropriate conservative management, including at least a 6-week course of therapy, self-exercise, and have had appropriate interventional pain management treatment and have failed to improve with the interventional pain management. Treatment of symptomatic contained or non-contained disc herniations is possible with Deuk laser disc repair with excellent results. Overall, the patients treated with cervical disc disease had a 95% resolution of preoperative axial pain and radicular symptoms with a single surgical treatment. The patient's VAS scores improved from 8.7 to 0.5, and the difference was significant. The procedure is a full endoscopic anterior cervical surgery with a small 4 millimeter minimally invasive surgical incision. The surgery can be performed outpatient. There is no fusion, no implants or biologics that are used during the surgery, and hence there are no fusion, implant, or biologic related complications. To date, we've had no complications. The surgery has been performed for 5 years. Recurrent disc herniation rate is 1.5%. Deuk laser disc repair is a proven, safe, and effective treatment for patients suffering with cervical disc disease with or without radiculopathy. For more information, I encourage you to read Surgical Neurology International and learn more about the procedure and its outcomes.